Hi, so I am Amy Browning. I am a nurse practitioner in the Central Florida area, and I have been treating multiple myeloma for over 10 years.
Hi, and I'm Theresa Bryant. I am an LPN here in the Central Florida area as well, and I have been working with multiple myeloma patients for about 8 years now.
Chimeric antigen receptor T cell therapy, or CAR T, has a specific side effect profile that's different. And so when we approach introducing CAR T to our patients, we have to educate them quite a bit about what to expect with CAR T. The neurotoxicity that we often hear about with CAR T is a little bit more obvious, of not being able to write a sentence properly or not being able to remember words or count backwards. But we've seen many examples of this neurotoxicity that isn't the traditional way. We had a patient, she played cards with her sisters every weekend and she won every week. And then after CAR T, she lost, and she was horrified that she lost. But of course, to us, that was like ding, 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 because there's some neurotoxicity that's not being captured by the traditional questions. We had a patient that was looking at the painting in our office and was seeing the river move. It was like a landscape. And he saw the painting move, which it wasn't, but of course, neurotoxicity. We had someone try to feed themselves and the fork was just missing their mouth, some coordination issues. And then
the other ones could be just simple, like everyday routines, and then they forget what their everyday routine is. We had a patient, he always, before going to the office, stopped at Dunkin' Donuts, and then would come to the office with a very large glass of Dunkin' Donuts. And we were like, "Where's your coffee at?" And he goes, "I don't know." And basically, he forgot to stop by the Dunkin' Donuts. The same patient told his wife he needed to go to the restroom, and then she just saw him walking in circles and then ended up in a closet instead of the restroom. So it's just little things that they were like, "Oh, I don't know. I forget what I'm doing." And it puts them in this fog, and they know that they have very strict routines, and it could just be off just slightly. So we know that that is the medication, and the treatment is causing these effects. So it's very enlightening when you hear it, but at the same time, it is something that we can correct. We do have options and therapies and treatments and things to do for that. So it's usually short-lived, but it can be very scary for our caregivers at first when they're calling us, and we're like, "It's okay. We can take care of this," but it can be frightening for the caregivers and loved ones.
And that's why it's so important that the caregivers know what to expect, even these kind of subtle things. We started educating our patients and the caregivers because it kind of surprised us when we first started doing CAR T that it wasn't always the traditional neurotoxicity that we read about. We had a patient who we'd been taking care of for years who had the funniest sense of humor, loved to tell jokes, very warm, very expressive, loved Bigfoot. And he came in, he answered every question appropriately. He knew exactly where he was, but it was like his personality was just turned off. And he was
flat,
very flat. But he insisted everything was fine, but his caregiver and his care team, we knew otherwise. And so we did treat it as neurotoxicity. And thankfully, his warm, fun-loving personality came back. But it is really important to make sure our patients know it's not always the traditional things. And then CRS, the cytokine release syndrome, kind of shows that the immune system is more excited, which is what we want. We want those T cells to be excited and to attack the myeloma and get rid of the disease. But sometimes that immune response is too much. It overwhelms the body. Patients mimic having infections. They may have fevers, drop in their blood pressure or their oxygen, mimicking these infections that could be real because these patients traditionally are immunocompromised because of prior treatment in the cancer itself. So of course, we're treating them with antibiotics. We're looking for the infectious workup, but there are medicines that we can give to kind of tone down that immune system. But fevers are typically kind of the warning sign that there's some immune system activation going on. Educating our patients to let us know if they're having fevers and how much of an emergency it is, especially if CAR T is being done in the outpatient setting, that timing of when fevers occur and when we can assess their blood pressure, assess their oxygen, give them that medicine that they need is vital. And then, of course, once kind of we get out of that window where CRS and ICANS is less of a concern when we're a couple more weeks out from CAR T, infection is the biggest side effect in these patients. Mm-hmm. Because CAR T works at having the T cell kill the bad B cells that make up plasma cells for multiple myeloma, it also kills the good B cells that make up your immune system that help protect you from infection. So infection is the biggest thing for these patients long term. So we want to make sure they're on the right prophylactic antivirals, antibacterials that we're preventing those opportunistic infections. We're looking to see if they need infusions of immunoglobulins to help boost their immune system. They may need to be revaccinated. There's all kinds of kind of long-term care for patients who are survivors of CAR T to help keep them safe. Typically, our patients, when they need CAR T or immunotherapy, they have become refractory to traditional chemotherapies. And so at that time, I'm having that discussion with the patient and their family about that pivot from traditional chemotherapy to immunotherapy. And so we're talking initially about how CAR T works, what are the risks of it. We're educating them extensively, not only about the risk profile of CAR T, but also the benefits of it and how we're going to monitor these patients so closely and what we're going to do if CRS or ICANS occurs in these patients. So we're talking about the importance of the caregiver, the importance of knowing how to ask those specific questions, of being in a specific area close enough to the hospital that if fevers do occur, that they can get to us quickly enough to get the appropriate treatment. And we layer education going forward. So from that initial visit, we start working on insurance authorization, which can take a couple weeks to a couple months. And so during that time, while they're getting other treatment, we're laying conversations in. We're having them coming in for a specific CAR T education class. We're doing lots of layering of education before it becomes time for them to consent and fill out the forms, to get their T cells collected. We're then educating them more while the T cells are being manufactured, and then re-educating right before we give the CAR T infusion. So these patients know what to expect. They know how to reach us. They know how we're monitoring them, and they know our goal of keeping them safe.